causes of behavior. Behavior is a response to a feeling or a need. Identifying the cause of the behaviors that we find challenging can help us respond appropriately to the person, the environment, the task, and the approach. PETA. That's interesting. I never saw it before. PETA. Yeah. Person, environment, task, and approach. I like to use the ABC approach. When I got a person with a challenging behavior, I like to look at the antecedent. What was the circumstance that led up to the behavior? Well, you know, it was in the evening, and they were in getting their bath, and there was a bit of a ruckus out in the corridor. Yes, okay. And what was the behavior? Well, we were in just helping them get to the toilet, and then he kicked one of us. Well, okay. Did you get hurt? No. I stood back, but he was really aggressive at the time, and I shouted at him. I said, "You got me," and then he got worse. And he got worse, and then he got really violent, and then we had to call the doctor, and the doctor gave him some a drug to settle him down. Okay, so if you had to do it again, what do you think about now? Well, maybe that agitation out there in the corridor triggered the behavior on the toilet. And maybe if we had got that person out of the corridor, out of their vision, and settled them down, and then left them alone on the toilet for 10 or 15 minutes, just leave them alone, or try to distract them then in a few minutes' time, you would probably get where you want to be. Okay? So the consequences were we could have had a staff person injured. So that's really important. So now we're going to deal with the antecedent, the environment. The behavior was this kicking motion and injuring, or potentially injuring the staff. The consequences are quite severe for the staff, probably quite severe for the patient too, because they could hurt their leg and break their leg. So that's an important one, isn't it? So how are we going to deal with that? Well, obviously we've got an education issue here with staff. Obviously now we're going to keep an eye on this fellow to see if there's something else going on that he's trying to tell us. Maybe he's kicking up, maybe he was constipated, maybe he was straining at the toilet and he was having pain. So we better get the doctor over and have a look at him. See that he's not constipated, or somebody should examine his belly, see that his bladder's working okay, and there's no infection around him. So we start thinking that way. So antecedent, behavioral, consequences, there's always a reason for the behavior. Sometimes the reasons are multifactorial. Usually there's a reason. Sometimes it's in the environment. Sometimes it has to do with the light. In the evening they're sundown and get more confused and agitated. Sometimes it's noise. Sometimes it's somebody else out in another room shouting, and then they hear that noise and they're disturbed by it. And they go back somewhere in their mind and that upsets them. So think of the antecedent. What was the behavior? Well, he was seeing the Pillsbury Doughboy, hallucinating, seeing the Pillsbury Doughboy. Yeah, so what's the consequences of that? Well, nothing really. So why, you know, if he's hallucinating, we know that in the advanced stages of dementia you can hallucinate. If the hallucination has no serious consequence to it, leave it alone. Because if you give them drugs for the hallucination, these drugs can cause strokes, can cause hypertension, can cause heart attacks. They're not benign entities. The drugs we use for behavioral disturbances in dementia have serious, profound consequences in the long term. So, the consequence again was not a severe consequence, so we don't have to treat it. Leave it alone. Let the Pillsbury Doughboy float off, and hopefully that hallucination will evaporate. Let it go. What? Yeah, give them cookies, yeah. That'd make them better.
How about a shot of brandy?
Brandy, you know, a shot of brandy might not be a bad thought. If the person always had brandy in their life, and I'm serious now, that might not be a bad thing at all. That may be exactly what they needed to settle down at night. But generally speaking, when a brain gets really advanced dementia, alcohol is a bad thing. So I usually try to give them non-alcoholic. You can buy non-alcoholic drinks now. And you can also dilute down the brandy. So I've done all sorts of devious things.
Does rum taste like rum?
Well, that's just it. You know, you can do it with cigarettes too, right? Because you can give them the cigarettes and don't light them. That can be a problem because the cigarette guys are used to lighting them, right? But you can buy the ones that when you suck on them, they look like they're cigarettes, but they're not. But then some of them can figure that out, right? You know, just because you got dementia can't mean you can't figure out some things. Rather surprising, like the fellow I talked about the last time. He jumped out through the window in the middle of winter, did a log roll. This guy is a paratrooper. Jumped out on the roof in the Miller Center, did a log roll, walks out in the parking lot, and stands up. And luckily the nurse found out there was a hole in the wall where he jumped out, where he knocked out the screen, and saw his footprints in the snow. We got him in time, brought him back in. They called me in to examine him, so I examined the guy. Not a scratch on him. He's after, you know, the height of this place here. Jumped off with a log roll, and he was a paratrooper in World War II. Just amazing. He never got injured. 88, 89 years old. So when he comes in, I said, "Now, why did you do that? Why did you do that for tonight?" Well, he says, "I was breaking out, you know. Here I am in prison, and I was breaking out. But I'm not going to do it. I got to wait till the summer before I break out next time." So he did learn something, right? Yeah. So the person's internal state, the need to go to the bathroom. We talked about that. The need for something to drink or eat. Pain, fear, cold or hot. Not understanding what he or she is supposed to do. So we got to try to figure out when that person is off, is agitated, what is driving it. Now, if it's around mealtime, think about the teeth, think about swallowing, think about a sore mouth, think about the jaw arthritis, because they're eating and something could be driving the pain then. If it happens at night, what are some of the things that might be going on if they get agitated at night? It could be nightmares.
They're lonely, they're scared.
Could be lonely because they're in a place and they always slept with somebody and they just got in the institution and they're scared and afraid. It could be somebody next door who's moaning, keeping them awake. Could be a bladder problem. Having to get up and go to the bathroom a lot, and they've forgotten how to get out of the how to get up. They get irritated with the bladder, and so at nighttime they're not sleeping and they're agitated. Right? So if it happens around mealtime, is another one. If it happens around bathing time, it could be that they don't want people touching them, or the staff person is more abrupt with them, or it could be the staff person, the way they're responding to the patient is triggering the aggressive, or it could be that they just don't like being naked in front of somebody stranger. So then you got to use your smarts on how to get around that, how to distract them. And the nurses, somehow or another, they do it. They do it really, really well. And that's not an easy job. You took the average doctor and asked them to go and bathe somebody with dementia, they come out with a black eye. I'm serious. That requires a very high understanding skill set and a very patient individual. Right? Patient, tender, kind, soft, warm. Those are things I would bring down the tension level and be able to cope. Right? Fear is a big one. Where I work in particular in the veterans, a lot of them have post-traumatic stress. We had a patient a number of years ago who at night got vomiting. And we said, "You know what? Why is he getting vomiting? He was never vomiting. He was always quiet." And he got vomiting last night and he tore down the curtain around his bed. So I said, "Gee, that's strange." Well, the nurse, I said, "Did we do anything about the environment recently?" "Oh yeah, we put new curtains up." "Yeah, and what were the new curtains?" "Well, you know, well, the staff wanted to brighten the place up, so we put nice red curtains around the beds." "So, what did you do?" We said, "Well, it was really fog last night. We ripped the curtain out." I said, "Well, let's see how he goes tonight." So guess what they did? They put the curtains back up. He got violent again that night and tore the curtain down again. So I said, "Ha-ha, there's something about these curtains." So give the family a call. We couldn't figure out what it was. There's something about the curtains now. He's in this room. He's a veteran. And he's tearing down these red curtains at night. Turns out he was a submariner in World War II. And the family told the story. He told them that there was a fire in the sub and he couldn't get out. Can you imagine what that must be like? And in the nighttime, when the lights went down in the room, the light in the corridor came through, and if you were in his room, the way the curtains were, it looked like, you're looking back, the wave of the, looked like fire. So when he woke up, he thought he was in the sub, and he had to get out. So we just took the curtains down, left them down in his room. We knew that wasn't the thing to do. So it was a lesson, but again, antecedent, what was the circumstance around the behavior? What was the behavior? What were the consequences of the behavior? Consequences here were quite severe because he could fall out and break his hip. Also, he was upsetting the other people in the room, so we could have some pretty violent stuff going on. So we figured that one out, and all we had to do was take the curtains out of the room. Put the old ones back, which were brown curtains. There was no problem. So, again, knowing the patient, knowing the environment, having some really good observations, and then when we went back and talked to the family, always go back and talk to the person who knows the person best. Because they often know what the tidbit of information could be that could be triggering the aggressive response. You're getting the impression that this is not an easy game. Those of you who are caregivers know how difficult this game is. This is a very tough game. And I say game, but that's not even the proper word. It's very tough caring for a loved one with an illness as so devastating as dementia. And we have to be able to provide you with as much support and relief, because we have to treat you the same as we do with a person with dementia, because your ability to care can only be as good as our ability to lower the stress that you have. So with this sort of stuff, I think we can help you get some tools to do that. So, the person's physical state. What if they have dementia and they got something else going on? If they got acute illness, they could be delirious and getting agitated. So if you got a quick change in behavior, an abrupt change in behavior with a person with dementia is a delirium to proven otherwise. A delirium is a sick mind that has an acute, ongoing medical illness. The most common cause of that is medications. So if the doctor, you're in to see the doctor the week before, and he took your loved one, he said, now I'm going to put him on a new blood pressure pill, and your husband or wife has dementia, and you put him on a new blood pressure pill, and it gets really aggressive and agitated. The problem is not, the most likely problem is the drug. If the drug fits in time consequence sequence with the behavior. That's a good theory to start with. Okay? An acute illness could do it, and a chronic illness that gets out of whack. So you got a person with renal failure, chronic renal failure, and they get an infection and their kidneys get much worse. So acute on chronic can make it much worse. Dehydration. Person stops drinking. Constipation. Remember I said before, sometimes when you're constipated, you can get urinary retention from that, you get abdominal cramps and pain. Person with your dementia can't express it verbally, and they're uncomfortable, and they get upset. And you might be out there just taking them out for a walk or trying to get them to go for a walk, and they don't want to go because they're feeling too sick. And then you would say, no, you got to get up out of bed, you got to go for a walk. No. You got to get up, then you get a, wow, pal, leave me alone. I don't want that, right? So the real reason is they're trying to tell you they're not well, and you're missing the communication. Hearing and vision impairment. The two things that you have to do with demented patients, wherever possible, is ensure that you optimize their vision and their hearing. Because vision is the great equalizer. If I'm dementing and I got poor vision, my dementia will be very much worse. I'll give you an example. I had a veteran a number of years ago who came into the pavilion with a diagnosis of dementia. And I admitted the guy, and when I was talking to him, he seemed pretty bright. And we were talking, having a chat, and he seemed to be really bright. And he sort of could relate things to me in a very specific way, which people with dementia can't. They relate things in cocktail chatter. How are you today? Oh, I'm fine. I'm doing okay. And you're looking great. No, that's fine. Yeah. Nothing specific. We asked them their age, like they couldn't tell you their age, right? Specifically. But this fella, he could tell me his age. I said, And yet, he was diagnosed with dementia, and on the mini mental status exam, they had him scored 15 out of 30, which is anything less than 26 is abnormal. He was 15, so he would have been on that scale moderately demented. And the guy didn't look like that. So I said, gee. So I checked his vision. His vision was really, really bad. He told me he hadn't had his glasses filled. He had cataracts, bilateral cataracts. And his hearing was really bad. His ears were blocked with wax. So I syringed out his ears. And sure enough, he could hear a bit better and he could communicate a bit better. And I sent him over to the ophthalmologist. And the ophthalmologist removed his cataracts. And I'll always remember when he came back to the ward, when he had his first cataract removed. And I walked in the room the next morning, and we took the bandage off his eye. And the tears were rolling down his eye, and I said, oh, the surgery was, he was so, like, upset. I said, you know, the surgeon, can you see? And he looked at me and said, yes, doctor. He said, it's the first time I can see in years and I can see colors. And within a couple of weeks of that episode, I retested him cognitively. On that MMSE test, what do you think he scored? 30 out of 30. Vision and hearing, remember. Vision and hearing, you can have a dementia, but the dementia will look a lot worse if the communication is further impaired by vision and hearing impairment. Remember I said, it's the communication difficulty that leads to the behavior. Communication difficulty is enhanced by vision and hearing impairment. So remember that one. You could make a false diagnosis of dementia on vision and hearing impairment. So I usually say, when I got a person with dementia, I pay a lot of attention to their vision and their hearing. Okay. Depression. Depression itself, people will say, oh, my memory is bad, I can't remember anything. But people with depression know that they don't know. People with dementia don't know that they don't know. They trivialize their losses with dementia. With depression, they maximize their losses. So a person tells you that they got a memory problem, and oh yeah, I'm forgetting everything. And they got a history of depression. It's probably depression that's talking and not dementia. But you can have depression with dementia. And depression with dementia can be a very tricky one indeed, because sometimes with depression you can get agitated. You can get agitated depression. If you've got a person with dementia and they get agitated with their depression, they can become violent. Usually the violence you can tell with the dementia and depression will have a pattern to it. So there could be a pattern around loss. So if the spouse died and the person has dementia, it's really fascinating. People with dementia still read nonverbal communication. I've had families tell me, you can't tell mom that dad died. Dad has dementia. I don't want him upset. We were having a hard problem dealing with his dementia. He doesn't know about mom being dead. As far as he knows, she's gone anyway. Don't tell him. Walk in the room. How are you this morning? There's something terribly wrong. I said, is that the way you feel today? Yes. Now, did that person read our body language? Possibly. Did he know? Who knows? But people with dementia, at some level, still perceive emotional loss. And that can be perceived sometimes. It can be a disinhibiting thing sometimes. So I've seen people on our unit lost a spouse and get very violent. They're agitated. They don't know what, they know something wrong. They can't put their finger on it. Okay? So remember that one. Anxiety can do it. Post-traumatic stress, classic. Just when you have post-traumatic stress, you tend to relive the traumatic event. So if they're in there and they're demented, and they got a TV on and a World War II picture comes up, guess what happens? You can have violence. So one of the things we say as a rule is not good for people with advanced dementia is to have that TV blaring unsupervised. If you're going to have the TV on with somebody with advanced dementia, make sure that it's programming that the person likes. Don't get fooled off by having somebody with a gun and violent things happening, because that person can't separate that from reality. And that could lead to a very dangerous situation with the caregiver. So remember, as a rule, overstimulation is bad as the disease gets more advanced. Okay? Social history. You want to know what that person did. You want to know what their habits were. You want to know what their friends were and their environment was like, because that would most likely set them. It's interesting, certain members of the family shouldn't see them, certain members should, depending on the effect they have on the person. We got a situation now in our unit where one of the daughters, the father can remember one daughter's name, can't remember the other. And the daughter that comes in the most is the one he can't remember. She's devastated. So when she comes in, she sets him off because she's so upset. So she's learned that she can't come in. Her other sister goes in. And then when she's feeling good, she comes in. And that's best for him. She realizes that. She understands it. Still is very emotionally terrible. It's an emotional roller coaster, isn't it? Really. Changes in routines. Remember, people with dementia like routines. If you change the routine, that can lead to a major behavioral problem. So getting back to when you're the LPN working in the nursing home, your routines ideally should go around the routines of the client, not your routine. You can change how you respond to the person with dementia. The person with dementia usually can't change how they respond to you. And remember, as the disease gets progressive and you lose verbal communication skills, you have to change how you respond to the patient if you're getting a negative response. There's something that you're doing is misreading, and look for the cause. Look for the cause. Ask why. Why did I get that behavior? What was the circumstance that it was happening before the behavior came on? What was the behavior? How severe was it? And if the consequences are severe, then you up the ante in terms of the institution that you're working in or in your environment for safety. Right? You have to look out for the caregiver as well as the person with dementia. Sleep. Sleep can be a real difficult one because sometimes the sleep-wake cycle gets reversed. But in dementia units, you can tell people to stay awake. It doesn't matter. They can stay awake at night because there's always somebody around that they're monitoring. But if you're living at home and your spouse is awake all night and you're burnt out during the day and you can't sleep because you're watching them because you're afraid they're going to watch, that's really, really hard. So then we often will go to trump sometimes the sleep routines, try to beat them out during the day so that they'll sleep at night. Sometimes I'll try melatonin, which is a sleep hormone that works. Generally speaking, if you're going to use medications for sleep, they're only to be used for a very short period of time. I will, as a trick, sometimes use an antidepressant with sleep side effects to try to get the person into a proper sleep-wake cycle, because sometimes they're not sleeping at night because the insomnia is a reflection of depression. Insomnia is a feature of depression. So if people are having sleep problems and they're demented, and the more severe demented, I think depression, and I often treat for depression to see if I get a resolution of the symptoms. Okay? Questions so far?